Good afternoon, everyone. So today we will be studying appendectomy. Okay, like a procedure, surgical procedure, which we basically need to learn in our final year. But since you have the early clinical exposure classes, so we will have a basic understanding of what is appendectomy. Okay. So before that, we need to know what is appendix. So appendix has been covered in this section, some part as far as I know. So what is appendix? What do you mean by is it an organ? It is a vestigial organ. When we call something as vestigial, yes. So basically, we will try to make this class as much as interacting, because I know that after 2 classes of anatomy it becomes a bit boring, but we will try to make it as crisp and informative as much as possible. So try to pay attention and please don't talk, because it causes some problem in like talking. Okay, especially left corner. So basically, appendix is a vestigial organ, and by the term vestigial, what we mean? Vestigial means it has no to less amount of use. Like the use is either minimal or nothing. Why I told that it is some minimal amount of use? Because sometimes appendix is considered to have some gut bacteria which maintains the flora of our microbiome, or like our gut health, maintains the gut health. Okay. So now this is a vestigial organ, and by the term vestigial we mean that something that has almost no use. Okay. But appendix has some amount of use because it contains some useful gut bacteria. Okay. What is meant by gut? Gut is our intestine. Okay. We have some amount of bacteria which makes it useful. Now coming to the various locations of appendix, where the appendix is basically present. So these are the various locations where the appendix is present. Basically, the appendix begins as an organ of the cecum. It begins from the cecum. Okay. So it has most of the relations according to the location of the cecum. So see here, as you can see this tube, this is the cecum. So in the intestine, the last part is the cecum, like duodenum, ileum, and at the beginning of the large intestine we have the cecum, right? So here this is the cecum, and from the cecum the ascending colon begins. Okay. Now, in respect to the cecum, this tubule-like structure, this is your appendix. Okay. Now, if it is behind the cecum, we call it, this is the cecum. Okay. This portion is your cecum, and this is the ileum. Okay. So, if it is like behind the ileum, we call it post-ileum. This is one of the location. If it is in front of the ileum, we call it pre-ileum. That is in front of the ileum. Okay. If it is in the lower part, we call it subcecal. Okay, subcecal. Cecal means cecum. Sub means below the cecum. Okay, it is subcecal. Okay. Then we have this one, which is the most common location of your appendix. That is your retrocecal. Retrocecal. Okay. Retrocecal means behind the cecum. Okay. So these are the various locations where the appendix can be found, and among them 74% to 80% of the time it is behind the cecum. Okay, we call it retrocecal. Now these are the various contents under which we will be approaching the appendix class. So first of all, location has been covered. Then coming to the blood supply. The appendix basically is supplied by 2 arteries. One is your appendicular artery, another one is your accessory appendicular artery. Now, among these 2 arteries, the appendicular artery is almost present all of the time. Accessory appendicular artery is not that much important. Now, appendicular artery is a branch of which artery? Inferior, inferior ileocolic artery, or just you can say ileocolic artery. Okay. Now, ileocolic artery is further a branch of which artery? Anyone? So, ileocolic artery is a branch of the superior mesenteric artery. Okay. Now, again, superior mesenteric artery is a branch of abdominal aorta. So, an abdominal aorta is coming from your heart. Okay. So, in this way, the whole blood supply is connected, and like all of them are coming from the heart only. Okay. So, the appendix is supplied by your appendicular artery, which is a branch of your ileocolic artery. Okay. Now, this is the blood supply. Coming to the main topic of today, for which we should have an idea of appendicitis. So, before appendectomy, like why we need to do appendectomy? But before that, what do we mean by the term appendectomy? Removal of appendix. Okay, appendectomy means removal of appendix. Now, why we need to remove the appendix? Inflammation. So appendix is like that friend of yours which does not provide any like help to your life, is no use for your life, but always some amount of problem. Okay, appendix is like that friend of you. So what we do, we wait for some time and then we cut that friend off. Okay, similar thing occurs in appendicitis also. Okay, we do appendectomy. We wait for some time. We provide conservative treatment. If, like by providing conservative treatment, the angle of the appendix gets reduced, then we keep it as it is, or like do elective surgeries, or like we just cut it off. Okay. Now, first coming to the first of all, let us break down the term appendicitis. What do you mean by citis or itis? Inflammation. And appendicitis means it just comes from the appendix. So it is inflammation of your appendix, right? Now, inflammation in your pathology, we study that inflammation has 4 cardinal features. What are they? Obviously, you don't know pathology, but you can have some basic understanding of what is inflammation. Swelling, redness, then what? So there are 4 terms. Basically, it is a pathological condition, and here we see tumor, dolor, rubor, and there was another thing. Keller. Okay, tumor, rubor, dolor, and keller. So these are some terminologies that has been taken from other languages. Basically, rubor, R-U-B-O-R. I'm not writing these things because this is not important right now for you. So rubor means redness. Okay. Dolor means pain. Keller means increasing temperature, and another one is tumor. Tumor means any swelling. Okay. These are the 4 cardinal features of your inflammation. Okay. Now, when these 4 cardinal features present in a particular structure, we call it inflammation of that particular structure. So, appendicitis has got its term like this. Now, there are 2 types of appendicitis. One is your acute case, another one is your chronic case. When we call something acute, less than 14 days. Basically, acute is something we refer to as like for short duration. Okay, ranging from hours to days or maximum 1 month. That is like acute case. In some of the cases, it is also extended. Acute is something that is present in the present scenario and it has not resolved yet. And chronic means something that has been going on, it has become a part of the life like this. Okay, it is not causing that much of a problem also, like in terms of pain or disturbance, but like it is present and we need to like do something to like resolve the case. That is chronic, which sometimes called chronic illness. Na? Suppose your diabetes is a chronic illness, Okay, then hypertension is a chronic illness. It is not like changing your day-to-day life as such, but in the longer viewpoint, it is causing problem. Okay, it is causing problem to the kidneys, it is causing problem to the eyes, then many other issues. So similarly, appendicitis can also be acute or chronic. Now we basically do surgeries in case of acute appendicitis. Now coming to the points, clinical features. Here's something we call Murphy's triad. From this Murphy's triad, Sean Murphy got his name. So basically, you know Sean Murphy? Good doctor. Very beautiful. So basically, Murphy's triad comprises of three cardinal features. Okay, one is your pain, another one is your nausea and vomiting, another one is your fever. Okay, these are the three main cardinal features that comprises your Murphy's triad. And other than this, there is another fourth feature that is your anorexia. What is anorexia? Not able to eat or like not feeling like eating. That is your anorexia. Can you tell me any other situation where anorexia is present? There is a psychiatric condition known as anorexia nervosa, where like a person doesn't feel like eating because he or she thinks that they will be gaining weight. That is anorexia nervosa. That is a nervous, like anxiety-based situation. That if I eat, I will gain weight. Okay. So now coming to the science. Okay. So last left corner, this bench. All five of you are talking. Using over that, but it won't talk. Now coming to science. Okay. So there are some science. Okay, from which we can partially confirm that like it is appendicitis. One is your like Medparnis point tenderness. Okay. What is Medparnis point? Which point is your Medparnis point? Okay. So basically, this is a junction starting from your umbilicus to the anterior superior iliac spine, and it is a junction in between of 1/3 medially and 2/3 laterally. What I told. So you know umbilicus. Let me see with the picture. See, can you appreciate that this is the umbilicus? This is the umbilicus, and here you look at the anterior superior iliac spine. Now, if we join a line like this, then medially 1/3 and laterally 2/3, and this junction is your Medparnis point. And in Medparnis point, there the patient feels tenderness. Tenderness means pain. Okay. Okay. Can you tell me the difference between pain and tenderness? Difference between pain and tenderness. Okay. So pain means when the patient tells that I am feeling pain, that is felt by the patient. Tenderness is something that is elicited by the doctor. So whenever a doctor does something to a particular person, and if that patient tells that he is feeling pain, then that is tenderness. So tenderness has to be elicited by a doctor. How do you elicit it? So whenever a doctor suspects appendicitis or like any painful situation, they palpate, and when they palpate, then if the patient feels pain, that is tenderness. And when the patient comes to a doctor and tells that doctor, I am having pain in my shoulder, that is pain. It is not tenderness. So these are clinically two different terms. Okay. Now there are other signs such as Schwarz sign, Lorentz sign, okay, the operator sign. Let me write these things. It means tie some structures. First of all, you need to tie the mesoappendix, that is the mesentery covering the appendix. You need to tie. Then you need to tie the appendicular artery so that bleeding does not happen. Appendicular artery. And after ligating both this structure, you crush the base of the appendix. You just crush the base of the appendix, and now the appendix becomes free. You just take it out using Dormia basket or something like that. You just take it out of the body. Okay, in this way. And so this is the main process of appendix, and then you close all the structures they are well done. Sometimes the peritoneum is not needed to suture, but the other structure you need to suture and then place it in its place. Now, coming to one extra thing, that is your appendicular lump. Appendicular lump is something like the infection, appendicitis. Sometimes what happens, in the last seminar, we talked about greater omentum. So greater omentum is known as the policeman of your abdomen. Why? Because whenever it sees any infection, it goes and covers it up. Now, appendicitis is an infectious, inflammable situation. So the greater omentum comes and overlaps it, and it makes the appendix looks like a lump. And in this situation, we cannot operate on it. So what we do? We first of all conservatively manage the patient using antibiotics, IV fluids and all. Okay. And after doing all these things, if the patient is getting better, then we wait for 6 weeks. That is 1.5 months. And after 1.5 months, we plan a date for the surgery and we do elective procedure. In surgery, we have 2 procedures. One is an elective, another one is an emergency. Emergency means something which we need to do it like at this point only. Okay, there is no waiting. Elective means we can wait for some time and can give a date and then do the surgery. In terms of delivery also, you will see elective LSCS or emergency LSCS. That is elective delivery of the baby, where the mother is given a date that you come at this date and you will do the surgery. And emergency cesarean section is where we need to do the cesarean section as soon as possible. Okay, so in appendicular lump, we do the conservative management and after 6 weeks we do the surgery. But if the patient does not improve and worsens further, then we need to do the surgery immediately. And that conservative management is given again another name, that is your Ochsner sharing regimen. Okay, no need to know these things. That is your Ochsner sharing regimen. Okay, that conservative management. So that's all from your appendectomy class. I have put 2 videos. So here you will see what? You will see laparoscopy instrument. Okay. In laparoscopy instrument, we don't give any incision. Okay. We insert one trocar. Trocar is something through which we need to insert a working instrument. Okay. From here, let us continue to see the video. See here, the trocar is, this is Viris needle. Okay. First of all, through Viris needle, we give one incision and then insert the trocar. This is the trocar. And through this trocar, we are inserting the working instrument. And now, here you see this picture. In this picture, we are entering into the abdomen. So this is the hole for entering into the abdomen. And now see this video here. We have entered into the abdomen. See, inside the abdomen, we are seeing some mesoappendic structure, some adhesions. Okay, is it clear? Okay, we can see adhesions and we will be clearing the adhesions and we will be identifying the appendicular artery. See, the adhesions are being cleared. It is inside the abdomen. This is the appendix. See, this is the appendix. You can see the inflamed anterior part. Now, what we will do? We will identify the appendicular artery. So the adhesions are being cleared. Now, with this working instrument, we have grabbed the base of the appendix and we will try to find the appendicular artery. So this is the mesoappendix part. It is a short video of 5 minutes only. See, surrounding areas you can see some white fluid-like structure. Whenever you see this structure, it means that it has undergone perforation. See, the surgeon is showing the perforated side. This is the perforated side. This one. This is the perforated side. Okay. So the appendix is already perforated, and in the lower part you can see some bluish discoloration. That is your gangrenous part or necrotic part. Now he is holding this part. That is the base with the stapler. This is stapler. Okay. And he will crush it or try to staple it. So with the stapler, he has stapled it. See, this is stapler. See the stapler, the metal pins you can see. This is the dormia basket. The appendix has been taken out, and it will be taken out later on. But before that, the surgeon will be clearing the surrounding structure. This is the stump area. He will be clearing all these fluids, and we will be seeing the pelvic area for any accumulation. That is the main thing only. Then he will be clearing the pelvic fluid after some time. Do you want to see the open procedure also? That is also a 5-minute video. See the accumulation here. See, this is the area. As you can see here, he is identifying the McBurney's point, and he will be giving either gradient or Rutherford Morrison incision. So what is this? He is doing the gradient incision because he is cutting. This is a cautery. Cautery has blue one and yellow one, another one is blue one. Yellow one is for cutting, blue one is for splitting, coagulation. So he will be opening, he has removed the skin and the superficial fascia, then he is approaching the aponeurosis. This is on retractor. Now after removing the aponeurosis, he will be approaching into the internal oblique muscle. Okay. This is the aponeurosis. This is another retractor. So the aponeurosis will be retracted on both sides. Then you can see the muscle, internal oblique muscle. So he has cut the transversalis fascia and entered into the pre-peritoneal fat area. Okay. Then he has approached the cecum. See, this is the cecum area. Now he will be finding the appendix. So he will be approaching digitally through the finger and pull it out. That yellow part is the mesoappendix. Now from here, the process is same as your laparoscopy surgery. Okay, he will be first ligating the mesoappendix, and then he will be ligating the appendicular artery. So that is the appendicular artery. This portion is your mesoappendix. He will be ligating both. See how he is carefully separating the appendicular artery from the base. And this is a clamp. Okay, this is not a scissor, this is a clamp. Clamp means we are holding it, we are not cutting it. Okay. This is a scissor. That one was a scissor. See, clamp has a red-shaped like structure. If you can see properly, which holds the clamp like this, locks the clamp like this. Now the appendix is out. He is suturing the base of the appendix. Oh, sorry, suturing the appendicular artery or ligating the appendicular artery. Now, here you can see the base of the appendix. The base has also been ligated. Now, we will cut out the appendix. See? Now, after cutting the appendix, we need to, like the appendicular stump that is left, it has to be sutured again. Okay? And then it is placed inside. And then we like close all the muscles, and sometimes the peritoneum area is not closed. Peritoneum is left as it is because it helps